Good evening, everyone, and welcome to this University Life Forum, where we have gathered together a tremendous panel of experts to provide an update on the coronavirus. I'm Suzanne Goldberg, Executive Vice President for University Life, and I want to welcome everybody who's here and everybody who's watching on the live stream. I know there's quite a group there as well. University Life brings our university community together for critically important discussions of a wide range of issues, including the discussion that we will be having this evening. Columbia, as you may know, is the size of a small city. We're about 50,000 in all, maybe some more, with students, faculty, and staff. And that makes it all the more important that we come together as a community for discussion of the issues of the day, and this is certainly a critical issue among them. University Life is also your hub for university-wide student life information and resources, and so we encourage you, whenever you have resource questions or information questions, to check out the University Life website and the University Life app. As everyone here knows, the rapid spread of the coronavirus in China and the much more limited but also notable spread of the virus in 20 countries, I'm sure our experts will verify, in a moment has caused tremendous upheaval to the healthcare delivery systems, to global travel, to global markets, for students in our community, to academic work, both here and abroad. Within the university, we have also been very active since moment one, developing policy and providing resources and support. And I'll introduce our panel of experts in just a moment to talk about all of this and more. First, I want to address a very important concern about hostility and bias that has been directed toward Chinese, Chinese American, and other Asian and Asian American students in our community and around the country and world in relation to the virus. And toward our students and our faculty and our staff. This is a problem, it's a serious problem, and it is one we're seeing not only at Columbia, but also around the country and around the world. As we're together and I should say within parts of the university. As we're together in a University Life Forum this evening, I want to take this opportunity to reiterate a core value and commitment of Columbia, which is to treat all in our community with dignity and with respect for each other's humanity. This is especially important at a time when fears about the virus can too easily foster suspicion without facts. And one of the reasons we've come together with this panel of experts tonight is to share those facts in a community that is committed to fact-based and evidence-informed analysis. Discriminatory bias and harassment has no place at all at Columbia, including discriminatory bias and harassment toward the many valued members of our community who are Chinese, Chinese American, and other Asian and Asian American individuals. At Columbia, we work every day to foster an inclusive and welcoming community, and today is no exception to that. I also want to be sure that our students in particular know where to turn if you are experiencing or seeing bias or harassment or anything that concerns you. So your Dean of Students and the Student Affairs team, the Student Affairs staff in your school is always available for you and stands ready to support you. You can always 24/7 report a concern or an incident to the university. And we can then investigate and make sure it reaches the right place. How do you do that? You can go to the University Life app or the top of the University Life website, and you'll find a report an incident or a concern button. And of course, our International Student and Scholars Office, and David Austell from that office, is here and available to support you as well. We fully understand this may be a stressful time for many in our community, and counseling services on the Morningside and Medical Center campus and many other resources are also available to support you. If you're ever not sure where to turn, again, just go to the University Life website or app, and all of the contact information for all of these resources is there for you. Now it is my real honor to introduce a panel of people for whom we are all fortunate that they are able to spend their time with us this evening. I'll be brief in my introduction so that we can get to the discussion, but I encourage each of you after our discussion tonight to look them all up, as they have done extraordinary and heroic work in many different areas of the world. So Dr. David Ho is the Clyde and Helen Wu Professor of Medicine in the Department of Internal Medicine at Columbia's Vagelos College of Physicians and Surgeons, where Dr. Ho is also the Scientific Director and Chief Executive Officer of the Aaron Diamond AIDS Research Center and the Director of the Wu Family China Center, which connects medical research communities in the United States and China. Under Dr. Ho's leadership, major scientific discoveries at the Aaron Diamond AIDS Research Center have fundamentally changed the trajectory of the AIDS epidemic and revolutionized our basic understanding of the disease, contributing to the developments of treatments that have moved HIV from an inevitably fatal disease into a preventable and treatable one. And I'll just say that for many, many years, Dr. Ho has been a personal hero of mine for his work in that area. Dr. Wafaa El-Sadr is University Professor of Epidemiology and Medicine at Columbia. And for those of you who don't know, University Professor is really one of the highest honors that a professor at Columbia can receive. She's also the Dr. Mathilde Krim-amfAR Chair of Global Health. Based at Columbia's Mailman School of Public Health, Dr. El-Sadr is an international expert in epidemiology and research on the prevention and management of HIV, tuberculosis, and other infectious diseases. She is also the founder and director of ICAP, which is a global leader in addressing HIV and other global health threats in partnership with governments and non-governmental organizations in more than 21 countries. Dr. El-Sadr is also the director of Mailman School's Global Health Initiative, which mobilizes the university community to address critical challenges in global health. Next to Dr. El-Sadr is Professor Benjamin Liebman. Professor Liebman is the Robert L. Lieff Professor of Law and the Director of the Center for Chinese Legal Studies at Columbia Law School. Professor Liebman is widely recognized as one of the world's leading experts in Chinese law. He lectures throughout China as well as in the United States and really probably everywhere in the world in his many areas of expertise. In addition to his extensive work on Chinese courts and tort law, he researches and writes on the impact of popular opinion and populism on the Chinese legal system. Dr. Melanie Burnett is Associate Vice President and Medical Director of Columbia Health here on the Morningside campus and an Associate Professor of Clinical Medicine in the Center for Family and Community Medicine at the Columbia University Irving Medical Center. Dr. Bernitz is an expert in college health, family medicine, healthcare administration, and public health, and her experience includes nearly 20 years of teaching and training of medical students and residents, as well as overseeing primary care and prevention services on college campuses. As head of Columbia Health on our Morningside campus, she supports the well-being of over 28,000 students here. So here's our format. We'll start with presentations from each of our panelists, with Dr. Ho and Dr. El-Sadr speaking for about 10 minutes each, and then somewhat shorter allocation of time to Professor Liebman and Dr. Bernitz. We then will discuss a little bit among the panel, and then turn to the audience for Q&A, both for people in the room and on the live stream. And just to give you a quick preview of that portion, we're really focusing on the questions. We've received a lot of them from you already. So I'll ask you, as you're thinking about a question, to really plan to keep it short, to about 30 seconds or maybe up to a minute if you have a comment you'd like to add, but no more than that. And we'll probably group questions together to try to get to as many as we can. So I'm really grateful to all of our wonderful panelists for being here, to all of you for joining us. And Dr. Ho, let me turn it to you to start our conversation.
Well, thank you, Suzanne, and it's a pleasure to be a participant on this panel. I'm a virologist, and I'm still in my first month on the Columbia campus. Our institute transitioned to the medical school at the start of this month, and start of January, I should say. And little did I know I would be in the midst of a viral outbreak, discussing about a viral outbreak. Obviously, everyone here knows that there's a big epidemic of a respiratory virus in China. Over 25,000 people have been infected and about 500 have died. So it's big, and as Suzanne mentioned, it's reached many countries, about 30 actually, and including some cases in the US. And it's due to a virus that we know as a coronavirus. It's now being called the 2019 novel coronavirus. We have known about coronaviruses for quite some time. They cause common cold. But in 2002, there was another coronavirus that broke out, and that's caused a disease we call SARS, for severe acute respiratory syndrome. And that began in the winter months of 2002 and ended in the summer of 2003. And so that's known as the SARS coronavirus. And that went away, and now we have this virus, which turns out to be highly related. It's about 80% homologous at the nucleic acid level to the SARS virus. And at the protein level, it's actually about 95% identical. And both cause a respiratory illness that comprise of fever, cough, sputum production, and in more severe cases, a pneumonia, with a mortality rate for this outbreak of about 2%. There's also another coronavirus called the MERS, or Middle East Respiratory Syndrome virus. And that one has not caused such a huge outbreak, but that one is actually associated with a much higher mortality rate. I'll just tell you a bit about what I know from inside China. We believe the initial cases occur in December. The first week of December or so, there are cases showing up to the hospital in a city called Wuhan in the province of Hubei. Wuhan is about 11 million in population, and Hubei province is about 50 million. And these cases went undiagnosed despite testing. So flu and many other respiratory viruses were ruled out. And testing was done for SARS as well, and they did not come up positive. And then as time went on, there were a cluster of cases being reported from a number of hospitals in that city. And epidemiologically, they traced back to a fish market that also have other live animals. I'll let Wafaa take care of the epidemiology, but it was at that juncture, in later part of December, some of the testing was done using new technologies, PCR-based, and one actually clinical diagnostic lab picked up that there was something that's akin to SARS coronavirus, and partial sequences that were posted. And then a few days later, they found similar findings in a cluster of healthcare workers from the city of Wuhan. To those of us on this panel, that raised the alarm of human-to-human transmission if healthcare workers are coming down with it. But the health authorities were saying that these were linked to the marketplace, suggesting there's a single source that spread to humans. So there was a lot of confusion, but China CDC entered the scene and very quickly confirmed the new coronavirus and published a number of sequences by the first week of January. And of course, from January on, we know the epidemic blew up, and I'll let Wafaa speak to that. And it's now causing a great deal of panic. As many of you know, or most of you know, the entire province of Hubei is under quarantine. And the population is enduring rather draconian steps to contain this virus. In terms of just in terms of relative comparison to SARS coronavirus, SARS probably has a mortality rate of about 3 or 4 times higher than what we're seeing with this outbreak, although the numbers are probably a gross underestimate of what's going on. At least the reports that I'm getting from Wuhan, people are estimating about 1% of the population might be infected already. But that's just speculation, and you could do the numbers. And it might be similar for the entire Hubei province. And Hubei province, as I said earlier, is about 50 million people. So that's a huge number. But we also should bear in mind a couple of other things. Although it is less lethal than SARS, its transmission rate is probably similar or maybe slightly higher. It's not extremely high like measles. And it's like many typical respiratory pathogens. You just need to know that the virus is largely there when a person becomes symptomatic, and it's largely in the respiratory secretions. A few cases have had diarrhea, and the virus could be found in stool as well. It's also present in the blood, but not in high quantities. In terms of one thing I would throw out there, we also need to compare this to other pathogens, particularly seasonal flu. Just bear in mind, seasonal flu on an annual basis has an average about 5 million worldwide cases. Okay, so, and we more or less take that for granted. And the mortality rate is 5 to 10 times lower than what we're apparently seeing with this new coronavirus for the seasonal flu. But that's still a huge number of deaths each year, 5 to 10,000 worldwide from just seasonal flu. So you have to put this epidemic in the proper context, related to SARS, related to MERS, but also to seasonal flu and many other things that we confront every day. Now, let me just end on a little bit of science, because that's what I'm tasked to do. Under Dean Lee Goldman's leadership, and the dean is sitting in the back, the scientists within the medical center have mobilized, and to some extent, the scientists and engineers in the engineering school, one of whom is sitting here, have also mobilized to see what we could do about this epidemic and make a contribution on the technical front. And that's what I've been busy with for the last 10 days or so, almost spending 90% of my days on this. So we decided that in the event that this epidemic doesn't come under control, like SARS, like seasonal flu, as warm weather approaches, we need to have a rapid solution. And so we have gotten a lot of reagents already, and we are going to very rapidly screen drugs that could block this virus replication. Particularly, there are 2 targets. One is the nucleic acid copying machinery, which we call polymerase. And then there's another enzyme the virus carries called the protease. And both are essential for virus replication. And we have set up both of these assays. We're going to screen a lot of compounds, a lot of available drugs or drug analogs, and new compounds to very quickly identify some that would have activity. And in the same vein, we are going to fish out powerful antibodies from convalescent cases. And these are very novel technologies, so that these antibodies could be used as therapeutics or even prophylactics. And now the current technology for drug manufacturing or antibody production is so good that on a time scale of 3 to 6 months, getting something for human testing is feasible if we move very rapidly. And then we're also making long-term plans to develop vaccines that might be relevant, but that has a much, much longer timeline. But whatever we're going to do within the Columbia community, we are going to do it to protect this family of coronaviruses. We went through the experience with SARS. Once SARS went away, all the scientific work on drug development, vaccine development, antibody development basically faded because lack of support, lack of commitment to carry through. I think what we need now is a firm commitment from multiple governments that we're going to find a permanent solution for this family of viruses. And based on the scientific information, we know that's possible because there are many, many conserved elements among all the coronaviruses that we could attack. And so that is what we're embarking on at the medical school.
And we are grateful to you for that and for all of this information. We'll now turn to Dr. Wafaa AlSadr for some of the public health and epidemiological dimensions of the work.
Sure, and thank you very much, and thank you for inviting me, and thank you, David, for setting the stage. I think what I'd like to start with is, of course, China has really borne the brunt of this outbreak, and I think it's really important to acknowledge the disruption, the suffering that's happening there, and for us to really be supportive and cognizant of the difficulties that the people are facing. And also to acknowledge that many Chinese scientists have made amazing discoveries and were at the forefront of identifying the virus itself. So let me talk about this virus and how do we think about communicable diseases? How do we think about infectious diseases and their transmission? And one of the most common questions that people always ask is how can you judge how an outbreak is going to evolve? How can you tell what's happening day in, day out? And one of the parameters that we always follow is to try to understand several elements of a certain pathogen or a certain virus. And most importantly, what determines the transmission of a virus is how long a person is infectious. That's very important. The longer a person is infectious, of course, that means that they're able to transmit it for that period of time. I think another element, the second element that's very important, is how many contacts that individual has to which they could potentially transmit. So for example, somebody who works in a school or in a crowded environment, they're much more likely to transmit than someone who works alone, as one example. And of course, the third element in determining the transmissibility or the trajectory of an infectious disease, the third important element is the way of transmission. And of course, with coronavirus, as David was saying, it's transmittable by respiratory tract, meaning that people don't have to have direct contact with each other. And these viruses that are transmitted by coughing and sneezing and so on are, of course, much more transmissible than others that require direct contact with blood or blood fluids, like, for example, HIV or hepatitis. So these are the three measures that we always take in mind in determining the projection of where an outbreak is going. And there's one measure that combines all those three, and we call it the R0, which is very important. And if somebody, and there's a way of calculating, if you have one person who has coronavirus, how many people are they transmitting to, potentially? And if that's less than one person, that means we're going to extinguish that outbreak. If it's more than one, it means that it continues to increase. So it's estimated that the R0 for coronavirus is now about 1.5 to 2. So we have to keep an eye on this, and it's evolving every day, and our knowledge is evolving every day. But you can compare that to measles, for example, where it's 18. So measles is much more of a risk in transmissibility and so on. So I think that part is a bit reassuring, which means that you could potentially dampen the transmission by identifying people early if they have symptoms, so they don't transmit to others, as well as, of course, to separate people who have the infection, who have symptoms, from other people who are susceptible to the infection. And then if you have a treatment, if you can shorten that period when they're sick, then potentially that could also make a difference in dampening the transmission of the virus. And very importantly, of course, is what you do. What do you need to do to achieve this? I think probably if there's one thing that I've learned in my career in infectious disease and public health is the importance of communication. Communication, communication, communication. That's really the message that's really critical. And it's never more important at a time like this. So what are some of the principles to keep in mind? I think number one is very important to anchor the information we're disseminating in evidence. Very, very important. There are lots of rumors that happen in the context of an outbreak, and it's very important to go back to the evidence and really to articulate the evidence. The problem is when there's an evolving outbreak, like with corona, the evidence is changing every day, and that ends up sometimes undermining the trust. But I think the more we're communicating and trying to share the evidence with the population at large, I think that's to our benefit. So evidence-based and communication. I think the other important is to develop trust. And developing trust means you have to be very transparent, announce early, and I don't know if China announced early enough.
We could comment on that later.
We can comment on that later. But I think to announce early is very, very critical. That's a very important principle. And I think also to announce, to talk frequently and be completely transparent rather than to dampen the communications about what's going on. And then I think very importantly as well, thirdly, is the importance of addressing people's concerns. You can't ignore them. If people have perceptions, whether they're right or wrong, they need to be addressed. They cannot be minimized, and that's really very critical. Every concern, even a rumor, has to be addressed as straightforwardly as possible, and I think that's why we're here today. So, I mean, those are kind of the key principles in trying to tackle an outbreak: is announce early, develop trust, and have trustworthy communicators, and then be evidence-based, very importantly, and then take seriously every concern that's raised by anybody in the public. Now, what do we need to have on the ground to be able to tackle an infectious disease and an outbreak? I think this is a very important piece of the puzzle, is you need to have very robust health systems. And by that, I mean it's the breadth of everything that's involved in addressing an infectious disease. You need to have, people, the astute clinician, who when they see that first case and they feel something is there that's just not right, or they see 5 cases, a cluster, that they immediately are astute enough to then report it. They need to be educated in terms of how to manage these cases, and also to be provided with the protective methods to protect themselves. So the health workforce is very important. Not just the clinical health workforce, but also the public health workforce. We need to have the laboratories. It's very critical. We need to have the supplies. We need to have the communication methodologies. And we need to also have as well the treatments, potential treatments that people need. So you have to address every element of the health systems in order to be able to tackle such an outbreak. And most importantly is access to data. And that's really very vital. And that's part of transparency, is to be able to judge every day what's happening, have those at your fingertips, so we can really say what is going on. Are we seeing a beginning of a dampening of this outbreak or not, and where are we seeing it? I think the fear is that, part of the fear is that, is this going to become an endemic? Is this going to continue and then will become an endemic kind of infection like other endemic infections like the cold or the flu that happens seasonally? And I think that's the fear. I think what the efforts now in China and elsewhere are to how do we contain this, and hopefully by containing it, we can see what happened to SARS, for example, is that it then is not anymore a threat to humans, as far as we know. So overall, I think what needs to happen is that for each one of us, I always feel like in times of crisis like this, whether it be the HIV crisis or corona crisis now, each one of us here on the podium, as well as all of you in the audience, both out there and here, we have to be the communicators. We have to be the communicators about the accurate information. We have to be the communicators about the do's and don'ts. We have to be the communicators about against the rumors. We have to be the communicators against the bias, and so on. So each of us have a huge responsibility within our own communities to be able to address this public health threat. I'm hopeful that because there's a global mobilization and that there's a global partnerships, that engagement of scientists from around the world, is that some of the public health measures that are being put in place, whether they be, we can discuss about some of them are likely effective, but some of them are not likely effective, and we'll talk about those, I think, is that with those, as well as some of the scientific discoveries that are now being made, that coming together, we can hopefully control the infection and the outbreak. Thank you.
Thanks so much. Before we turn to Professor Liebman, I know there are a number of people standing in the back. If you have an open seat next to you, can you raise your hand so that, just raise your hand so that anybody who wants to grab a seat, please come down and join and take a seat. There's plenty of places to sit. And while people are taking their seats, I just want to underscore something that Dr. El-Sadr just said, and I think was implicit in Dr. Ho's comments as well, which is that each of us does have a significant responsibility to learn and then to share what we know. Even those of us who, unlike the two of you or the three of you on this panel, are not medical professionals, but in the case of Professor Liebman and myself, law professors, or in the case of many of you who are studying and working in different fields, whatever your fields are, to spread out the knowledge just as, in I suppose a positive deviant version of the spread of a virus, the reverse spread, the spread of the knowledge.
Stress of knowledge and information.
Right. So with that, I will turn to Professor Liebman.
Great, thanks. Thanks for including me in this important discussion. I want to echo what's been said already, just recognizing this is an incredibly difficult time for a lot of people in our community. People who have family back in Hubei, but also people who have family in isolation or voluntary quarantine elsewhere in China as well. And I just want to urge, echo what's been said, I urge people who are to reach out if they have questions or concerns. I also wanted to say a personal note, which is I spent a lot of time in Wuhan. It's part of the reason I think I'm here. I actually did a lot of research on medical disputes in Wuhan and elsewhere in Hubei 10 years ago or so. So that's sort of why I fit into, I think, to this discussion, although I'm obviously not a medical expert. And so I have a lot of friends in Wuhan and have been in touch with a lot of them over the last few weeks. And I also want to say that, that there is I'm here, my job here is to put this in sort of a political, legal context. There is a temptation sometimes when we talk about US-China relations or what's going on in China to put everything in a political context. And I think, this, as has already been said, what's going on now really, I hope, transcends politics. And we should remember there are thousands and thousands of ordinary people in Wuhan doing the hard work, both the medical professionals, but even basic things like the people building the hospitals, the people getting people food every day. This is a massive challenge that's being faced, and a lot of people are working hard on the front lines there. So, but with that said, I'm going to say a few words about what I think the outbreak suggests about governance in China, and also just a little bit about implications for US-China relations. So, and again, I say this as a non-medical expert. So, first, the China's governance system, China's political system, did not cause this virus, right? But it seems pretty clear, at least from a non-expert, that it made it worse. That the initial cover-up slowed the response and probably contributed to the rapid spread. And I think many of us who lived through SARS, I was in Beijing at the early stages of the SARS outbreak in 2003. We're surprised to see a repeat of this cover-up, this dynamic of a cover-up then followed by a massive state response we're seeing repeated now. But I think maybe we should not have been so surprised, right? China remains a system in which local officials fear responsibility for their actions, and I think often are incentivized to cover up bad news. One side effect of the anti-corruption campaign under Xi Jinping has been fear of action by local officials. There's a fairly widespread recognition of this dynamic. And when it comes to epidemic control, I think this dynamic's arguably made worse by legal rules that centralize information flow through national authorities. Now, I don't know what actually happened. We've seen this back and forth between the local authorities and the national authorities. It's actually quite remarkable to see the local authorities pushing back against the narrative that they covered things up. But it's clear that actually the public health legal infrastructure does require notification of an epidemic to go through Beijing. And so that probably slowed things down in this situation. Now, we've also seen that the Chinese state does have this massive capacity to respond when it wants to, when it sort of gets focused on a problem. We're seeing this now, the construction of hospitals in just a week. I mean, there's probably nowhere else on earth that this could happen. But I think it's also important to recognize that once the state turns on this spigot of control, it's also hard to stop it. And I think this explains why we see so many local authorities outside of Hubei taking extreme measures against people, not just from Hubei, or in some cases from people from Hubei, even though they haven't been in Hubei for months or even years in some cases, right? If you're hukou, if you're residence permits from Hubei, in some cases people are being targeted even though they haven't been there. But also we're now seeing reports of local authorities across China quarantining anyone who comes from outside, say, that village or that township, regardless of where they've been. So those seem to be fairly extreme response. And I think the explanation for this is pretty simple, right? Once the central government turns its focus to addressing this problem, no official wants to be seen as weak in this system. All right, that was my first point. All right, so I'm just going to say very quickly the other 2 points, and maybe I'll just go over by 1 minute. That's what happens when you give a lawyer half the time of the doctors. I just think we have to realize that there have been major improvements in the healthcare system over the last 15 or 20 years, but the system remains under-resourced and hampered by weak primary care, low levels of patient trust, and for many still high out-of-pocket expenses. There are huge disparities in the quality of care between the major urban hospitals and second and third tier facilities. And patient-doctor conflict remains common, fueled by a history of corruption in the healthcare system. So again, I think things are clearly getting better, and the Chinese state has done a lot to improve healthcare over the last 15 or 20 years. But this backdrop, I think, does make these challenges even more difficult in times of crisis. And then finally, I'll just say, what does this mean for U.S.-China relations? I don't want to overstretch this. This is obviously a difficult time for U.S.-China relations. Lowest point in a decade. I think many of us would hope that this crisis might provide an opportunity for areas of cooperation, right? This is a common threat that we all face. Are there ways that there can be more done to cooperate? And obviously at the science level, doctor level, there's a lot of cooperation, I think, underway. But from the government to government level, the initial signs aren't very good, I think. According to the US, China's been slow to allow US experts into China to help. According to China, the US has been slow to offer assistance and has violated WHO recommendations in issuing a travel ban on non-citizens who've been in China. I think there's a real risk, and we're seeing this a little bit already, that in both countries, the current crisis is being used to fuel xenophobic or nationalistic narratives. And I hope I'm wrong about this, but I think the initial signs on this at the government-to-government level are not good. So I'm done, but I am going to just sort of throw a question on the table, if I'm allowed to, which is, I think I would just love to hear from our medical experts their assessment of the US government policy, right? What was this justified or not? I think there's a lot of questions out there about whether this was medically based, politically influenced, or some combination of all of the above.
And that sounds like one of the first questions we'll take up after Dr. Bernitz speaks. Before turning to Dr. Bernitz, I just want to point out that often at Columbia, when we gather to talk about pressing issues in our time, we're talking about issues that are out in the world but may not be directly affecting our community. And this, like any spread of a serious infection, raises issues. Any public health risk that's in the United States raises issues for our own community as well, and requires a marshaling of the best information and the best resources to figure out how to do one of our primary tasks, which is to ensure the well-being of all members of our university community. So with that, let me turn it to Dr. Melanie Burnett, who will speak with us about the Columbia response.
Thank you, Suzanne, and good evening, everyone. Thank you so much for the opportunity to share with you what's been happening here at Columbia University as we learn more and hopefully provide some transparency and clarity about some of the things that have been happening here and the evidence that has backed them up. We're really fortunate, I believe, to be surrounded in our community by so many experts, and we've been receiving up-to-date information as the identification of the 2019 novel coronavirus occurred and as the situation has continued to evolve. Here at Columbia University, we've got a structure in place for responding to and managing widespread emergency issues. And in evaluating policy and protocols, the university looks at national guidance, international guidance, from many sources, the Department of Health, the CDC, the World Health Organization, and many more. So as soon as there was an understanding that this situation was going to have pretty far-reaching implications, a response team comprised of senior medical and public health experts from the Columbia faculty, some of whom are here today, along with senior officials from Columbia Health and university administration convened together. This group has been convening almost daily, sometimes twice daily, including the weekends, to ensure we're making the best evidence-informed decisions for the university community. And this protocol that we've put in place is the same protocol we've used in previous situations, including in around measles, as well as back in 2014 when the Ebola outbreak was first identified. In addition to those groups, the university convenes the Infectious Disease Working Group. This is comprised of representatives from a wide range of key offices across our university and our affiliate schools, with representatives from health, public safety, campus services, facilities, housing, dining, human resources, environmental health and safety, communications, university life, epidemiology, risk management, the list goes on, but really the groups of people who can really help inform how to act within our community and provide the best resources for our population. These groups together really review the status of the outbreak, campus needs, and action plans as the situation grows. By mid-January here at Columbia, we were tracking the recommendations from our experts and responding to inquiries from within our community. I shared a health advisory with the community on January 23rd describing what we knew at the time, which included that there were no cases in the area, some information on transmission as we knew it, and symptoms. And at the same time, CDC was recommending avoiding non-essential travel to Wuhan. We also provided resources for those returning from the area who had symptoms. It was also important to reinforce general preventive measures. As we've mentioned, at this time of year, we're worried about colds and flu in general, so we reinforce the importance of hand washing, covering your cough, coughing into your elbow, regularly cleaning surfaces, and so on. And we updated university websites and prepared frequently asked questions for those sites. We continued over the course of the next week as new information emerged and case numbers increased across the globe to update those FAQs. And we've been responding to individual concerns, particularly around transmission, isolation, and use of masks, which we'll address. The student health services have refreshed their screening protocols, so all our staff are trained and updated on the guidance coming from these national guidelines around evaluation of returning travelers, as well as Department of Health guidance for triage and care of suspected cases of coronavirus. Of note, as I've mentioned, we are in the peak of cold and flu season, so our staff are well trained to evaluate any type of respiratory illness. We're currently seeing dozens of cases of flu every day, and so it goes without saying, if you develop any medical symptoms that you're concerned about, please reach out to your campus health center, to your primary care clinician, to a local urgent care center, or to the emergency room. So as the situation continued to evolve, on January 29th, Provost Katz-Nelson and Dean Goldman shared another message with the community to reinforce the university's approach, and in line with the CDC's issuance of a level 3 travel warning to determine that the university would not provide credit or funding for student travel to China at this time. And for Columbia employees, faculty, or staff, they would need to receive approval from their dean or provost prior to travel. The university has also been reaching out throughout this time to all our registered travelers in China and the surrounding areas and providing them information and resources as needed. For returning travelers, they were reminded of the resources should they become symptomatic, and Columbia Health set up a telephone line staffed from 9 a.m. to 7 p.m. Monday to Friday with nursing staff fluent in Cantonese and Mandarin, so we could respond to inquiries from around coronavirus, and also ensuring that our after-hours coverage was available 24/7. On Friday, January 23rd, the Health and Human Services announced travel restrictions that would become effective February 2nd that were mentioned here. And the US State Department elevated its travel advisory to a level 4, which means do not travel to China. And as a result, a further community message was shared with our community on Saturday, February 1st, and asked that all travelers returning from mainland China within the previous 14 days complete a confidential form and share details of their recent travel, the locations and date. We had a really strong response to this, and many members of our community submitted the form with their information. And based on a risk evaluation, some members of our community were recommended to stay home and self-isolate for 14 days after their return. We have been able to assist students who needed to change their living location or had concerns about food, and the provost has provided support by asking faculty to be accommodating during this period to our students. Anyone who returned from China more than 14 days ago is past that concern of the incubation period and doesn't need to self-isolate or take any specific further action. So what's happening now? Columbia Health has been checking in with our returning travelers. We're working with the faculty and deans to ensure appropriate academic accommodations are provided. Our nurses are responding to telephone inquiries. Our counseling staff are available to provide telephone counseling or in-person counseling as needed. And we're continuing to work with the New York City Department of Health and the CDC around evaluating risk. And I do want to reinforce that currently we do not have any people under investigation for coronavirus in our community. The FAQs that are on the University Preparedness website are updated daily to address the common inquiries we've been receiving. One of the most common questions has been around masking. There's some interesting data out there that there's little high-quality scientific research to gauge the effectiveness of wearing a mask, and the studies have mixed results. We know they may catch bacteria shed in liquid droplets, such as bacteria that transmit TB or measles, but may be less effective in filtering out fine virus particles, the kind of particles we see with the cold or possibly with coronavirus. CDC is not recommending the widespread use of masks for those without symptoms, but if you wear one anyway, make sure it fits well. Everyone should also be reminded to practice good hand hygiene because we're in cold and flu season. We also want to share that some people wear masks for other reasons. Sometimes it's a preventive measure, they want to protect themselves. Sometimes people are worried about air quality, so it's important just to not make any assumptions about why someone is wearing a mask. We'll continue to respond to inquiries, and we'll continue to check in with you all in our community. Many of our travelers, as I mentioned, are past the 14-day incubation period. And I just want to share that we're incredibly grateful for everyone's support as we navigate this evolving situation. To emphasize what my colleagues have shared, this is a developing situation, and we likely won't know the full extent of this outbreak for maybe weeks or months to come. The best course of action, to echo what was shared, is to, as a community, to stay updated with accurate information and to continue to support each other. Thanks so much.
Thanks so much, Dr. Bernitz. So, before I pose Ben's question to the panel, I want to just acknowledge something that is really special and extraordinary about being part of Columbia University, which is that in short order, we can pull together the world's leading experts from the medical, legal, and community health standpoints to talk with us all as a community, to learn together, to think together, to become informed, and to address both the public health implications of this disease and also of this virus, and also the community implications of the virus. And I'll mention on that note one other email message that went out to all students at Columbia, so hopefully all of the students in the room and on live stream saw this message, which was from our Vice President for Student Affairs, Joseph Greenwell, who is here, reinforcing the message of maintaining an inclusive community and continuing to look at fact-based and evidence-informed practices and to reinforce the core values and commitments of Columbia as a university, which are to the dignity and respect for all individuals in our community, and to not let fears of a virus get in the way of carrying that respect toward all of our members of our own community and those outside of our community as well. So let me turn to the question, which I think is a medico-legal question that Ben asked, which is, and maybe this is really David and Wafaa to both of you, how do you see the U.S. government's response to the virus in terms of the ban on all travel to China right now. I think you
I have a mic on. I'm not sure I have a clear answer on that because I think the information coming out of China is incomplete right now in terms of the true or not figure that Wafaa talked about. How transmissible is this? And in terms of the mortality rate, we don't have a very good idea of the numerator or denominator. And so to be definitive, I think is problematic right now. And so I could see our government would try to err on the, quote, safe side. And for the past few years, we're kind of happy on banning travel of any kind, or particularly by foreigners anyways. So let me just sort of touch on an issue that Ben mentioned. I lived through SARS as a consultant to the government in Beijing, Hong Kong, and Taipei. And I had 6 trips in the course of 3 months to those places. And I went through SARS, and I was really frightened and disappointed by how it blew up in the way Ben described. And then I was impressed how it came under control when certain infection controls measures were implemented. And the government officials actually asked me to write a piece, which I did, suggesting what should be done. And this is a paper that's published in the journal Nature, entitled, "Is China Prepared for the Next Epidemic?" And now, with this outbreak, I pulled that back out and looked at it. And one could sort of give China a mixed grade. On the science front, it's pretty impressive. They've trained a lot of scientists and technologists and other folks. And then once they realized it was a cluster in mid to late December, they sent the scientific team and worked on it and came up with the diagnosis very rapidly. And the numerous complete genome sequences were provided within a week after that. I don't think in the US we could do any better. So on that front, they would get an outstanding grade. But in terms of training people in epidemiology, disease surveillance, reporting, that aspect, as I look back on those older recommendations, the grade is not so good. And the biggest deficit is obviously transparency and the lack of an appropriate command and control structure, so that it's unclear, even to the head of CDC, whom I know, China CDC that is, whom I know, it's not clear how he's going to report it. And so there's finger pointing downward and upward, and ultimately, we would think, given the Chinese government structure, it's got to be top down, as is the case for most things. So that aspect, I think it failed the population. And if we take a specific example, human-to-human transmission was reasonably well documented by late December, early January. The public announcement of that fact did not come out until January 24, 25th. So a 2 to 3 week delay. If you had a fire and you wait 20 minutes before ringing the bell, it could get out of control, and this is why we see the explosion. And to me, that's extremely sad.
Yeah, I think, and that's the announce early part of the mantra that I mentioned before, the transparency and announcing early and often. I think your question is really made me wonder about several things. During the Ebola crisis, I did go to Sierra Leone at the height of the outbreak in Sierra Leone, and at the time when there was reluctance about Colombians going to a place where there was a much more deadly disease, actually, Ebola. So I think there's you kind of wonder about the wisdom of complete banning, because personally I felt very compelled that we could, as ICAP and my team, we could contribute to trying to help in some way. So it wasn't, and we also knew that we could minimize our risk and minimize the risk to the community coming back. So I do think one has to be careful in these complete bans that may, in a way, undermine also the global response. We're a global community, and I think people have different things to contribute, and I think it's really important to understand, to appreciate that you can't block, a country completely. It's not going to happen. It will never happen in this day and age. So I think we need to be careful about how this messaging, and especially at a moment where there might be the need for specific expertise or knowledge and so on. I do think that the another aspect of this is clearly I really always feel badly about pointing fingers at China. I mean, we've been guilty of it too in the US. I mean, it took our government, I think, 6 years to acknowledge HIV, right, David? And again, why was that the case? Because of politics. And it was because of the people who were affected and the political situation. So I think the lesson that we should have learned around the globe is that you have to acknowledge early and be transparent and don't judge the people who are affected by whatever disease. So, but it seems that we need to history needs to repeat itself, and we keep on falling into the same pitfalls of trying to deny something or hoping to go away. I do think also that some of it is fear, and it's fear at all levels. China has enormous, actually, strength, even in epidemiology. I've been very impressed. This China CDC, there are amazing experts there that are, the surveillance that they do is remarkable. I do think it's the issue of who has the authority to speak, and how can they take the risk of bringing bad news to somebody above them. And I think that's kind of the issue of the evidence, and the evidence remaining suppressed rather than being shared and being transparent. But the expertise in China is broad and deep, and we should acknowledge that, and hopefully that's what's going to enable China to overcome this outbreak and be prepared for the next one.
Thank you both so much. So we're going to open to questions now. I want to just clarify one acronym in case everyone here is not familiar with CDC. That stands for Centers for Disease Control. We have one in the United States. There's one in China. Maybe there's one in every country in the world. That's your area of expertise, not mine. So just to remind you, for questions, and if you want to make a comment, to keep it short, certainly any comment should be under a minute, because we have a number of people who have questions. If you're comfortable doing so, I'd appreciate if you would say your name and what school you're from, if you're from a school, or what office you're from if you're not. And we'll take a couple of in-person questions from the room and add a couple of live stream questions and take a handful of them and toss them back to all of you, okay? Go ahead. I think I see. I'd like to go with students first, if we may. So if you're a student and you have a question, please keep your hand up.
Okay. So hi everyone, I'm Xin Ho, a sophomore at Barnard College. And first, thank you so much for addressing the racist bias and increasing hostility towards Asian and Chinese students in the community. So due to the limited time, I won't give specific examples, but I do want to expand on the mask-wearing cultural difference between China and the United States. I was educated at a very young age to wear a mask to decrease my chance of being infected and to simultaneously protect others. So wearing a mask really does not signify that person is sick. And I do understand this time of the period, everyone is stressed. And I think all the anxiety towards the coronavirus is because we still have so much expectations in our communities. And we do all expect a community of compassion, inclusion, and when difficulty comes, people turn to the problems but not each other. And we actually emailed deans at Columbia College, CEs, and Barnard College, and we believe the school is gonna treating the racism issues very seriously, and we hope everyone can stay safe. And thank you again for the forum.
Thank you very much. Other student questions? Again, your name and your school, if you're okay with saying that, and your brief question or comment.
Hi, my name is Michael Sutton, a PhD student in biomedical engineering. Again, thank you all for coming. It seems like a lot of the concern and borderline panic about the coronavirus is based on the fact that we don't know a lot about it. There's been comparisons to the seasonal flu. We know tens of thousands die, but most don't, that you feel like crap for 2 weeks and you drink fluids and then you're fine. Do we have any data on individuals who were cases who no longer are cases and haven't died? And do you see any of that data being available anytime soon as far as better understanding the trajectory of you're infected and at some point you're okay?
Our panelists will be able to keep all of these in mind when we take a few more questions,
Yes.
if that's okay?
Yes.
Sure.
Oh, hi. My name's Michael. I'm a senior in Columbia College. And I was wondering, you guys talk a lot about planning. What's your plan when we have the first case in New York City? What's your plan when we have the first case at Columbia? And what's your plan if we have multiple cases at Columbia? Thank you.
Great. Thank you very much.
Okay. Hi, my name is Marat Bitlikbalt. I'm in Columbia College and I'm a freshman. And I'm from Mongolia. So in Mongolia, because the government is so afraid of the virus spreading to the country, a lot of absolute measures are being taken. It's now compulsory to wear a mask outside. Schools, universities, kindergartens are now all closed. All travel from China is banned, and it's now legally required to report flu or common cold symptoms. These policies are having a straining impact on people's lives, and there are shortages of food and other consumer goods because most of our imports come from China, and my parents are not very happy. My question is, are these measures all necessary, or is it overkill?
Okay, let me just build on one of these questions with a related question that we've received from the live stream, which is a version of a question you asked, but the sort of how severe is this virus really? And in a particular way, if a 30 to 60, and maybe I'll lower that age because to encompass our student body.
Yeah.
If an 18 to 60-year-old healthy individual catches the coronavirus, does that affect the rest of their lives, or is it something like the flu or a common cold? So we have a lot of questions on the table.
I could take
David
a few.
or Wafaa, let's start.
In terms of the clinical outcome, we know that 90+% recover. So, and recover for these acute viruses, not like HIV or hepatitis C. Once you recover, you're essentially cured of the virus infection. And if you take drugs for flu, they might help you, but your immune system will mop it up. And flu is gone until the next encounter. How deadly it is, I tried to lay that out a little bit. It's about 5 to 10 times more lethal than seasonal flu, excluding the 1918 type of pandemics. For the seasonal flu, it is more aggressive than that. It's 3 or 4-fold less than SARS. So that gives you an idea. But much of the mortality is still in the elderly and in people with underlying chronic diseases, pulmonary diseases, cardiovascular, diabetes, etc. There are, however, reports of death in otherwise healthy individuals. We don't know why that is. The number of deaths outside China is minimal right now. I think it's 2 or so. And with the supportive care, would have taken some of the lethal cases through and rescue them. We don't know that. In terms of mask, I understand because I spent my early years in Asia. There is a much greater habit of using masks. I grew up in Taiwan, so there's a great deal of Japanese influence, and the Japanese wear masks when they're sick. So one huge use of masks is to not infect others. And then for people who need to come in close distance with sick individuals, like a doctor, wearing a mask makes a lot of sense. And then masks also are used for other purposes to keep up dust and such. But from what I see, much of the mask use in China is kind of silly right now, right? If I see people riding a bicycle on an empty street wearing a mask, that's not needed from a medical perspective. So I will say that, I mean, there are many other cultural factors involved here, but I'm just speaking strictly from medical and scientific perspective.
Yeah, I'd just like to maybe build on this. I do think we should not underestimate the flu. There are hundreds of thousands of people who die from the flu every year globally. And I think this is something to remind everybody, take your flu shot. Because
and we still have them available.
And you have them available. Because, you know, as we heard, is that if you have a fever now and body aches, that could be the flu, but now you become, you know, concerned that it might be coronavirus. So actually getting the flu shot is very, very helpful because of decreasing the illness as well as mortality from the flu. So remember that for this year and next year and the year after. I think it's important to keep, from the data we have, and it's evolving, as David said, only about 10% of the cases that have been confirmed have been severe, and about 2% have died. So the vast majority of the cases of coronavirus thus far, based on what we know, have been, people who have been identified and confirmed with coronavirus infection have not been severe cases. So that's the good news. But nonetheless, even 2% death is high. That's 2 out of 100 people. So it's still, you know, alarming. But the vast majority of people do not get severe illness, and the vast majority do recover. And we don't know yet how long it takes them to recover. A description of the total, panorama of the illness itself, we don't know enough yet because everybody's just trying to cope with the crisis. And I think over the next several months, we will learn much more once the data and publications come out regarding this. Just very quickly, I do think, in terms of the, are those issues suffered in Mongolia, are they justified? And I think part of the problem has been, is when you have such draconian measures that are put in place, the fear is that people actually hide, so that people who may have symptoms may be afraid to come out and have symptoms. So part of the problem when you create fear and of an illness or fear of a disease and fear of isolation and stigma is that people actually delay coming to the health facilities and delay coming for evaluation. So I think we have to be cautious, is that the more we create this kind of draconian measures, is that might actually make it worse and make the response less effective. So I think that's an important thing to keep in mind, is that the more open and measured the responses, the more likely people are to engage positively in trying to actually have an effective response.
Around the question about what happens when there's the first case in New York City, the city is ready. The Department of Health in New York City and departments of health across the country are ready to manage cases. They send daily messaging to healthcare providers, to hospitals, to let them know how to prepare, the signs to look for, what the actions need to be taken, how to isolate patients effectively, how to get rapid testing done, and all such measures. So I believe the city is ready to handle the first case, or multiple cases, in fact. Similarly, Columbia is ready. We have measures in place for early identification in the same way. We have relationships with all the local hospitals, both here at Mount Sinai, uptown, at New York Presbyterian, so we would get immediate notification if a member of our community were under investigation or were confirmed to be a case. And then we work hand in hand with the Department of Health around identifying close contacts and taking the necessary measures to prevent any further spread. So I feel very confident in the measures that are in place. Similarly, the groups I mentioned have been thinking through what happens if there are multiple cases and how we would support those students, their contacts, their families around living accommodations. As was mentioned, in most young, healthy people, this is going to be a recoverable illness, but you'll need to stay home, you'll need to rest, you hopefully won't be hospitalized. How do we house someone appropriately, isolate them, feed them, make sure they're taken care of? And all of those plans are in place and ready should we need to activate them.
I think it's important. Preparedness almost has two sides to the mirror. I think the preparedness in terms of the health system and the Department of Health and all of us is very important, but we also need the collaboration, the cooperation, the trust with the community. Because we depend on the community to be forthcoming. We depend on the people who feel ill to actually be willing to disclose that they feel ill and to come and be evaluated and so on. So we can't lose track of the importance of this intersection between all of us and scientists or lawyers or healthcare providers or Department of Health and the community that we serve. And having trust is probably the most precious thing that we need to maintain.
So
I would just say that being a newcomer to Columbia, just in the last 7-10 days, I've been called into 30 conference calls.
We're ready.
I think
Welcome.
The university has done an admirable job of preparing for the what if situation, all the way from students to staff and throughout the campus.
So I have a number of questions from the live stream that I want to consolidate. And I know we had somebody from a colleague on the faculty at Teachers College wanted to make a very brief 15-second comment. So let me just put these questions on the table. And they all have to do with self-quarantine and spread of disease and concerns about classrooms where people might be sick. Should there be, why isn't there a mandatory quarantine of students? Should we be avoiding congregating in groups? Can asymptomatic people be spreading the virus now? What about that person I'm sitting next to in class who seems to be sick? Should I be moving away? That's my rephrasing of a question that was asked. What would be the most effective way to confirm the virus in Manhattan and to protect oneself? I think you've addressed this, but the questions continue to come. And then there's one quick comment from over here.
Yes, well, thank you so much. I'm Judy Kuryansky. I'm on the faculty at the Department of Clinical Psychology at Teachers College, and so it's good to see PNS and Mailman and the law school and the health department. So I just wanted to say that as part of the clinical psychology department, there's really rampant issues psychologically that have been triggered by this virus. That two of my students are here from the clinical psychology department, the vice provost and the Community Affairs Department is all concerned about the emotional issues. I was also in Sierra Leone during Ebola, and for you, Dr. Ho, in SARS in Hong Kong. So these emotional issues have to do with very crying, anger, upset, discriminations between the emotional stigma and the emotional issues. I think this is something that we should all be concerned about.
Thank you very much for raising that, and it actually picks up on something that Ben said early on about people also being very worried about their families who may also be facing quarantine or otherwise. So I think with that, we've put a lot of questions on the table here, so let me turn this back to all of you to jump in, and I'll say that we are about at time, but we started a little bit late, and I know there are a lot of questions and that these are particularly important to people. So with the permission of the panelists, we'll go through this round of questions.
I will just take a small part of the questions, leave many to the rest of the panel. In terms of transmission from an asymptomatic carrier, that was not what was observed for SARS. And I suspect it's something similar for this one, although we don't know for sure. There was a scary report in a major publication from Germany that suggested a lady from Shanghai went there and transmitted to a cluster of Germans, and they said that lady appear asymptomatic. Upon further investigation, that lady was symptomatic. So there is no firm documentation of a asymptomatic transmission, although there are anecdotes that I'm hearing, but they're not firmly established.
I think it's important also when you look at when I looked at all the cases that have been reported outside of China, so external reported confirmed cases, I would say 99.9% of them had contact with someone who was from Hubei province. So if you're sitting in a classroom, the odds and the person next to you has the sniffles, the odds is they have a cold, okay? It's not, that they just have a very common cold, so it's, but I think so all of them have been with someone who's visited the province within the last 2 weeks prior to the illness. So I think we're defining very carefully the epidemiology. It doesn't mean that there won't be more external cases from elsewhere, because now there are reported cases from elsewhere. But at least for the time being, that's where most of the vast majority of the external reported cases have been reported.
May I just build on that for
yes.
one moment? Just around who you're sitting next to, should we be congregating in groups? We don't recommend that we restrict any congregating activities, but as always, practice social distancing. Don't share drinks, don't share utensils. Think about who you're exchanging secretions with, and that way protect yourselves as you do all year round, and especially during cold and flu season.
And wash your hands.
Please wash your hands.
Frequently.
Having had the benefit of watching Columbia Health communicate across many flu seasons, and hearing consistently the wash your hands advice, and then seeing that in major media, and I don't read the scientific journals, but I assume this comes from there. The wash your hands advice seems to be the strongest prevention advice out there. It seems the most basic, and is also, it seems, the most important. I know there are other questions, and perhaps our panelists can stick around for a few minutes to talk with folks. I want to thank all of you for coming and being part of this University Life Forum. I want to thank our tremendous panelists and experts from around Columbia who are working to develop and support all of our Columbia community and beyond to really tackle the challenges of this virus. The video of tonight's discussion will be up online for you to share. Again, you can find every resource you could want at the university on the University Life website and app, so please don't hesitate to look there. If you're a student, to speak with your Dean of Students, to ask us questions at universitylife@columbia.edu, and take advantage of all of the resources here for you at Columbia Health, on the Medical Center, and at on the Morningside campuses. Please join me in thanking our really extraordinary panel.
Thank you.